Google Google form. That is the only way for us to know who is joining our lectures and who's interested in joining our group. And so I would really appreciate it if those of you that are joining today will fill out that form and give us your feedback. Thank you so much for that. And then I would like to introduce our speaker for the day. So Fatma Amer is a licensed certified genetic counselor who graduated from University of Cincinnati and Cincinnati Children's Program. In 2018, Fatma currently works remotely as a cancer genetic counselor at Genome Medical, which is a telegenetics company that offers genetic counseling services across the United States. Prior to joining Genome Medical this year, she worked as a cancer genetic counselor at Dana-Farber Cancer Institute in Boston, Massachusetts for 3 years. And Fatma currently lives in Queens, New York. But she has grown up across the United States, Pakistan, and Qatar. And she lives in Islamabad. She had lived in Islamabad for 2 years and Lahore for 5 years in her childhood and between the ages of 6 and 13. So her roots are deep, deep in Pakistan. And Fatma is passionate about expanding access to genetic services and underserved populations in America and beyond. And so without further ado, I would get the show started and stop sharing my screen and let Fatma take the show on the road. You're on, Fatma.
Thank you, Aisha, and assalamu alaikum, everyone. Let me just figure out how I'm going to share my screen. So give me 1 second here. Okay, perfect. All right, so does that show up okay for you guys? It looks like, there we go, got the thumbs up. Okay. So assalamu alaikum, everyone. My name is Fatma. Thank you for that introduction, Aisha. I am a genetic counselor, as Aisha mentioned. So this is, and I work in cancer genetics. So this is a very near and dear topic to my heart. So thank you all for taking the time on this Sunday to come, spend your time here when you could probably be doing other things. So I really appreciate it. I wanted to make sure I acknowledge Sada Khan. She wasn't able to speak with us today, but she is certainly has contributed to the creation of some of these slides. And so let's just go ahead and get started. So I wanted to start off with mentioning some objectives at first. So the objectives of the presentation are to, 1, establish background on cancer formation and cancer genetics, provide a general overview of hereditary cancer, and 3, to discuss the role of cancer genetic counseling and testing. And I've left some time at the end because my favorite part will be to hear from you guys and see what questions you guys have. So I figured it would be a good place to start to just kind of talk a little bit about cancer in Pakistan and what we know. I found this really interesting letter to the editor by a general surgery resident by the name of Fiza Arif, just published in a publication by King Edward. And she had talked about the increasing burden of cancer in Pakistan. And in it, she mentioned some excerpts that I thought were worth mentioning. I've included in this slide. Is one that, cancer is one of the leading causes of demise, along with ischemic heart disease and respiratory infections in Pakistan. She mentions that common misperceptions regarding diseases and lack of knowledge and awareness about environmental and genetic risk factors of different types of cancers have contributed to increased incidence of cancers in the Pakistani population. And she also points out that screening allows early detection of various carcinomas, aiding in management of the disease at the earliest stage, as majority of the neoplastic conditions that are common in Pakistani population have good prognosis. So basically what I want you to take away from that is that, 1, there's lots that, we can contribute to in terms of helping understand. And in particular, right now, the purpose of some of this talk is to kind of talk a little bit more about those genetic risk factors for cancer, but recognizing that the power in doing that is it can really allow for screening at an earlier stage that can change the outcome for patients. So I was trying to get some numbers on what cancer incidence is like in Pakistan, and I was able to find this report by the World Health Organization's International Agency for Research on Cancer. They have kind of like a global cancer observatory, and they kind of put together stats for a lot of different countries. And so this is just a nice kind of breakdown of what are some of the common cancers that might be seen in Pakistan, or the number of new cases, particularly in 2020, that were identified. And so some of the ones that we'll be touching a little bit more on are breast and colorectal in today's talk as well, which, as you can see, makes up a significant piece of it. But I also wanted to point out that data is important. So if you looked at the little blurb here in this report, they talk about how they get their data for these numbers. And with regards to incidence, they were able to pull data from the Punjab Cancer Registry. However, for mortality related data, they really don't have country specific data available. But so they've kind of put estimates together from neighboring countries and their data. So I wanted to highlight the importance of having a national cancer registry in Pakistan, which to my knowledge does not exist at this point. There are some region specific and hospital specific registries that exist, such as the Karachi Cancer Registry, the Punjab Cancer Registry, or the Shaukat Khanum Cancer Registry. But there's, of course, those might not necessarily translate or capture the full picture of cancer burden in Pakistan. And I shared this, just a piece of this finding from the group at, I believe, Aga Khan University, that put together a paper that talked about that there is variation in cancer figures between, different data that is coming out of different parts of Pakistan. And it reflects in part the different ethnicities within Pakistan and the diversity we have within the country. But it also points towards a need of having a national cancer registry. And the reason that's important, because it can really just allow us to have a better picture of what cancer is, what cancers are kind of have the most burden in the country, and also allows decisions to be made as to where resources need to be allocated most. Okay, so let's go into talking about what is cancer. And the reason I wanted to do this is because we talk about cancer a lot and the word gets thrown out a lot, but not too many people actually know exactly what we mean by it. But to understand what cancer is, it's important to understand genetics. So you're at a great lecture to help understand that. So I know because this is the Pakistan Society of Medical Genetics, I'm sure many of you are probably familiar with this, but for anybody who's not, just wanted to make sure we're on the same page. So as you know, our bodies are made up of billions and billions of cells. And so this is just like an example of, this is what your normal cells might look like. And if you kind of zoomed into one cell, you know that there is your genetic information that's packed in there. So you guys probably remember this from any of your biology classes or such if you've taken them. But as a reminder, your genetic information is packed in the nucleus of your cell. So I don't know if you can see my pointer, but this, here you can see your genetic information gets stored in here, and it's very nicely organized. So it's packaged in what we call chromosomes. Sometimes the way I like to help explain that is if you think about our genetic information being a set of instructions, they're all stored really nicely in like an instruction manuals, like an instruction book. And just like a book would have different chapters, similarly, our genetic information is kind of stored in different chromosomes, which kind of serve as like those chapters. And then just like if you opened a book and looked at chapters and inside saw that it was made up of different words, we have different genes that make up those chapters or those chromosomes. So the genes are kind of like the words that encode some meaning in it. Now, genes, their function, they, like I said, their genes kind of encode a function or a job. They're kind of like a recipe, if you may, that go on and give instructions to your cell on how to make a specific protein that can physically then go do those functions that need to be done. And we have about 25,000 genes. So there's lots of different jobs that get done within our cells. Now, what is cancer? So now that you have kind of a little bit of basic, reminder of what genes are and all of that, and how our cells are kind of put together, cancer is a term for diseases in which abnormal cells divide without control and can invade nearby tissues, so also called a malignancy. And so you can see here kind of in this image how this, there's this cancer you can start to see that's not only an uncontrolled growth, but also is invading into nearby tissue. So the reason we had that little genetics 101 was just because genetic changes cause cancer to happen, typically acquired genetic changes. So that means changes that have happened over your lifetime. And, I thought this was a nice image that kind of showed, as you grow older, you may acquire more and more changes in your DNA. Many of them don't really matter. They don't typically, or they're not really harmful, but you might have changes that can get acquired in specific genes that can then allow for cancer growth to happen. And how do these changes happen? There can be exposure to certain things in the environment. So for example, exposure to UV radiation, to chemicals, sometimes viruses can play a role, lifestyle factors like smoking and such, but also just our regular aging process and dividing cells, can sometimes cause genetic changes to happen by accident. One of the common phrases I use with my patients is nature is not perfect. And so sometimes those errors can still happen. And then, what we're obviously going to focus on later on in this talk is about the hereditary aspect of things and when someone might inherit a genetic change and how that plays a role. But I wanted to point this out to remind you that all cancer is genetic, okay? It's all happens because of changes acquired in the genes of your cells that drives it. Okay, so we're going to focus a little bit on cancer genes. So remember we talked about how these genes kind of encode certain instructions. They have different jobs. So there's a set of those genes amongst the 25,000 genes. There's a set of them that are what we call cancer genes. And cancer genes have various roles. So there's different types of cancer genes. The common goal of all of them is to protect the cell from becoming a cancerous cell. But some of the more specific, types that exist and what their kind of usual functions are kind of listed out here. So we've got tumor suppressor genes, which basically their job is to stop any cell growth or divisioning from happening. So for example, if their job is to see, okay, well, if the cell's starting to grow a little bit uncontrolled, they go ahead and stop that. So if that gene is not working for you, then, or if it's inactivated, then it's not going to be able to stop that uncontrolled growth. And therefore, that's how cancer can happen. Similarly, there's another set of genes that's called the proto-oncogenes. And these are ones, their normal job is to stimulate cell growth and division at usually a normal pace, right? We know we're growing up, our cells are always they need to have a lifespan and need to be replaced and such. So our proto-oncogenes are typically very important for our purposes. When someone has a mutation in a proto-oncogene, or when it stops working, the way it typically works is it gets permanently turned on. So it's kind of constitutively active is the appropriate term, which means that it's kind of on overdrive. So, it causes the cell growth and division. At that point, it's typically called an oncogene. And then there's a set of genes that are DNA repair genes. And these are genes that their job is to go ahead and proofread your DNA and correct any errors that have happened. Remember, we talked about acquired changes can happen in our genes over our lifetime. So DNA repair genes are there to fix any errors that they notice. So if your DNA repair gene's not working, then you're going to keep acquiring more and more mutations. So that can, of course, lead to cancer as well. Now, I mentioned earlier that all cancer is genetic. So, like we talked about, every cancer genetics plays a role in cancer formation, cancer development. All cancer is genetic, but not all cancer is hereditary. So that's what I want to talk a little bit more about. So what is hereditary cancer risk? when we talked about those genes, earlier from that picture, one thing that all you may recall as well from many biology classes you took is we have two copies of each of these genes. So in particular, for example, let's say for a cancer gene, we've got two copies of each of them, one from our mom and one from our dad. And so this here, I'm a very visual person. So this here is just like just a description of, okay, so this is any random cancer gene that you have, right? This is two copies of it, one a copy that you got from, one parent and the other copy you got from another parent. So what is hereditary cancer risk? So let's take a look. So sometimes what can happen is you might have been born with one copy of that cancer gene from one of your parents not working properly. And that can happen because of a genetic mutation. So there might be a change or an alteration in one copy of your gene that makes it not work properly. You still have the other copy that works, but this one copy not working, what that can affect is there's an increased risk that you may have then of cancer compared to the general population. Because now in your cells, you really only need to lose that other copy by an acquired gene from like some kind of environmental exposure or something for the cell to have lost both copies of the gene, which then if the cancer gene is not working, whose job is to protect the cell from developing into a cancerous cell, then of course what that means is the cell is susceptible to becoming a cancerous cell. And so that is hereditary cancer risk, is when you are born with a change in your genes that increased your risk of cancer compared to the general population that might have both copies of the genes working from the time that they're born. But I like to put it in perspective. If we think about all cancer, most cancer is not hereditary. Most cancer is sporadic. So kind of like what we talked about earlier on, where it can happen just due to environmental exposures, some certain risk factors, and the lifestyle like smoking, et cetera. Aging, can increase that risk as well. But also as a reminder that nature isn't perfect and sometimes our cells just create an error. But hereditary cancers really only represent 5 to 10% of all cancers. And that number is variable based on what cancer type we're talking about. But for kind of overall, 5 to 10% is probably a good number. Now, you'll notice that there is also another piece of the pie here, which is the 10 to 20% of familial cancers. And often what that is where we might see multiple people in a family have cancer diagnoses, but we just don't really know. We don't have a genetic explanation for it. So we've done genetic testing, we've not found anything. So sometimes it can be, there's possible explanations for it. So possible explanation that maybe our genetic testing just isn't good enough. So we're maybe missing something, or maybe there's a gene we've not discovered yet that could be explaining some of that family history, or genetic factors we just don't understand yet. But also sometimes maybe a family has a shared environment. And so, for example, a family that's growing up next to an industrial site that might have harmful, chemicals being released from them. Maybe they're all just exposed to the same, environmental exposure that can increase their risk of cancer. So not necessarily that they were born with anything different in their genes, but that they just had a common exposure. So that all gets kind of lumped into that familial category. So as a genetic counselor, one of the things I do is, take family histories for my patients, and there are certain clues that I'm looking out for. Now, if you pay attention on this slide, I will give you a tip that there is going to be a little pop quiz at some point later on here. So definitely pay attention if you are. So some of the clues that can happen with hereditary cancer that we kind of take note of is, one, we might see multiple generations affected with related cancers. So, in this family, for example, and for anyone who's not familiar with the family tree or a pedigree like this, typically circles are females, squares are males, and anybody that's diagnosed with the cancer is shaded in, and the type of cancer is listed underneath them along with their age at which they were diagnosed. So in this family, for example, we're seeing multiple generations are affected. So that's a clue potentially for this being due to a hereditary cause. They're also with related cancers. So we'll learn a little bit later on that breast and ovarian cancer we can see together in certain hereditary cancer syndromes. But we also are noticing young ages of diagnosis. So typically under the age of 50. So here, for example, you're seeing this breast at 42, a breast at 38, et cetera. That's also an indication for, why are they getting diagnosed with cancer so early? That's unusual for that cancer type. And then, of course, sometimes rare cancers can be a clue as well. So ovarian cancer is actually pretty rare in the general population. So to see 2 different ovarian cancers in this family is certainly concerning. And then multiple primaries, that's not reflected in this family here, but multiple primaries just means that someone was diagnosed with more than one cancer type. And so, if someone's had more than one cancer in their lifetime, that could also potentially be a clue for there being maybe a genetic predisposition that someone was born with. So let's talk a little bit about genetic counseling and genetic testing. So what does a genetic counselor do? So I kind of like to think of us as being at the intersection of being a healthcare provider for the patient, their educator, but also their counselor. So some of the job, what my job typically involves, and what, kind of more generally speaking, somebody's making lines. Okay. Anyway, so we will, we can review your personal and family history to assess your risk. So when we meet with the patient, we take their personal medical history, we take their family history and assess their risk that way. We will discuss benefits and limitations of genetic testing, and then appropriately order the right test for the patient, depending on the history that we've taken. And we also then are able to interpret the results and communicate them to the patient. We are trained to provide psychosocial counseling during our sessions. So as you can imagine, some of these topics can be difficult for patients to talk about, can bring up a variety of feelings that they may have. So we're trained as genetic counselors to also be able to address that. And then, of course, we also then work with other providers to ensure that appropriate follow-up care is set up. So, for example, if someone does have, a reason to get more screening for certain cancer types, we want to make sure that that is, that they're connected with the appropriate doctor or physician to be able to get that screening. Now, with genetic testing, I wanted to point out that there's kind of 2 different types of genetic tests that, we think about in the world of cancer genetics. So there can be germline genetic testing or somatic genetic testing. Germline genetic testing is the genetic testing that is done on normal cells. So typically a blood sample, a saliva sample is used. And, we're looking at the normal, DNA in your cells that you were born with. So these are your inherited DNA. We're looking for any inherited DNA changes that are reflected in all your body. We're typically doing this to test for a hereditary cancer syndrome, of course, and that's more so the type of testing that I would order as a genetic counselor. Now, there is also somatic genetic testing, which is genetic testing that is performed on cancer cells. And so typically what's the sample that's needed for that is like a piece of the tumor or blood if it's like a leukemia or some kind of hematologic malignancy where the cancer cells are the blood cells. And then it's typically testing for any acquired DNA changes that are isolated to the tumor. So these are changes that are reflective of the tumor, but not actually reflective of the normal DNA that this person was born with. And typically the purpose of somatic genetic testing is to assist with any targeted treatment. Okay. So what, this is a great kind of innovation in the world of oncology where patients can have their tumor be tested and look at the specific genetic profile there and get appropriate, more targeted treatments for it. Okay, so again, as you can see, I really love visuals. So this is, kind of drawing out the 2 copies of a gene, right? And let's just say that this gene spells out, go to the theater. So what does the genetic testing do? It's kind of like a spell check. So in this case here, both copies of the gene look right, go to the theater, they're spelled out right. So this would be, would result in a normal or negative test result. The genetic testing might find that one copy of the gene is misspelled and now no longer makes any sense. The meaning of the gene is lost. The other copy is still fine, but that one gene has lost its meaning now. So that is an example of a positive or a normal result that the genetic testing might find. But sometimes you might have changes in a gene, like here, for example, where now it's RE instead of ER. And that is kind of what the lab might classify as a variant of uncertain significance or an inconclusive result. And typically that's just saying that the lab just needs to gather more information to see, is this change a change that is actually changing the meaning of the gene, or is this just a normal change, a normal variant, depending on where you're from in the world? That is just a normal change. It doesn't actually impact the gene harmfully. And we know that most variants of unknown significance or uncertain significance actually end up being normal changes in the DNA when they are reclassified. So this is just kind of a nice little illustration to show you that genetic testing is basically like a spell check. Now, this is like an example of hereditary cancer syndromes. So, there's two different examples I'll walk through, just making sure how I'm doing on time. Yep, we should have enough time. This is great. But I think what I want to do before we talk about that in particular is talk about how hereditary cancer syndromes tend to be inherited. Now, as you may remember potentially, if you've taken a biology class in the past, is there are multiple ways in which your genes can, in which inheritance can happen for certain genetic diseases. Most hereditary cancer syndromes tend to be what we call autosomal dominant. So I'll focus just on that for our purposes today. And basically, this kind of nicely illustrates what that means. So like we talked about, you have two copies of each gene. So here, for example, here's the mom, here's the dad. They have two copies of a cancer gene, right? And for mom, both of her copies are working, they're doing their job, all good. Dad, one of his copies is not working. So he has a hereditary cancer syndrome, okay? Now, when they have children together, there's a 50-50 chance that they're going to pass on either copy of their gene. So mom is always going to, give a working copy because that's all she has. She only has working copies of the gene. Dad, however, has a 50-50 chance of passing on the copy that works to his children or the copy that does not work. And therefore, really what autosomal dominant inheritance pattern means is that there's a 50-50 chance for the children of someone with the syndrome to have inherited the cancer syndrome. Also, then there's typically a 50-50 chance for any siblings or for your parents to have had the syndrome as well. Now, hereditary breast and ovarian cancer syndrome is an example of one of the most common hereditary breast cancer related syndromes. So the genes that are mainly associated with it are BRCA1 and BRCA2. So basically, if someone was born with a change in one copy of their BRCA1 gene or BRCA2 gene that makes that gene not work properly, they have hereditary breast and ovarian cancer syndrome. And the implication of that is that they can have then an increased risk of certain cancers. So in females in particular, the most significant risk is for breast cancer risk. And then women can also have ovarian cancer risk. There's pancreatic cancer risk slightly for both males and females. Prostate cancer risk and male breast cancer risk is also a risk factor for males who have hereditary breast and ovarian cancer syndrome. And then also melanoma is one that we see a risk for typically with BRCA2 mutation carriers. Now, one thing I always like to reiterate is having a genetic mutation like this. So let's say someone was born with a BRCA1 or 2 mutation. That is not guaranteeing that they're going to develop cancer in their lifetime. So it's not 100% risk that they have. The risk varies. We know it's increased compared to the general population's risk, But what that level of increased risk is, it's different depending on what gene we're talking about and what cancer type we're discussing. So in the case of BRCA1 and 2, for example, just as an example to give you the variability in those increased risk numbers, breast cancer risk, which as I mentioned was the most significant cancer risk, that risk can be anywhere between 50 to 80% lifetime risk for a female compared to the general population's risk, which is 12% in women. So it's a pretty significant increase, not 100, but significantly increased. Similarly, but if you look at another cancer risk here, so like pancreatic cancer, for example, that increased risk we estimate to be about 3 to 5% lifetime risk. So that means that 95 to 97% of people with the mutation will never develop pancreatic cancer in their lifetime, but there still is that 3 to 5% lifetime risk, which is increased from the general population's risk, which is much lower. Lynch syndrome is another hereditary cancer syndrome that is relatively common and has a number of different genes that can be associated with it. So if anyone is born with a mutation in any of these genes, any of these 5 genes, MLH1, MSH2, MSH6, PMS2, and EBCAM, they may have Lynch syndrome. And what it means is that they have an increased risk of a number of different cancer risks, but really the main ones are colorectal cancer, and for women, endometrial cancer, which is also called uterine cancer. And then, of course, there can be other cancer risks as well. So I've listed them out all here, but just like in the previous example, the level of risk is different depending on what cancer type we're talking about and what gene we're talking about. So the risks associated with mutations in MLH1 will be different than those in a different gene here, for example. Really, the purpose of figuring out this information and seeing whether or not someone has a hereditary cancer syndrome is to not only be more aware of what their cancer risk is. We now know that their cancer risk is not that of the general population. It is different. It is increased for certain cancers. Knowing that information is really powerful because it allows then people to undergo potentially extra screening that can allow for early detection of cancers. So for example, in the case of a BRCA1 or 2 mutation, a woman might start doing her mammograms or breast screening not only at an earlier age, but she would also be recommended to have breast MRIs. So she's getting extra screening than a woman would in the general population that allows for early detection of cancer. So that if, God forbid, she were to form a breast cancer, it's being picked up at the earliest stage possible where it's most easily treatable. Similarly, there can be risk reduction options or even in some cases prevention of cancer. So for example, with Lynch syndrome, where the main cancer risk is for colorectal cancer, colonoscopies are a great example where, you're not only going in with it's a procedure where you kind of take a look at the colon from the inside with a scope. And that process is not only able to detect any early signs of any colorectal cancer, but it's also preventing colon cancer from happening by removing any precancerous polyps that were there. So definitely really impactful information that can be gathered from this in changing the outcome for patients. Now, what does genetic testing involve? Kind of continuing on a little bit on that, I thought it was worth mentioning that our field is evolving. We're learning more and our practice is evolving with that as well. So if we were having this talk maybe 10, 15 years ago, we'd probably be talking about single gene testing where we typically just test 1 or 2 genes when we're seeing a patient. But we've really moved into the era of multi-gene panel testing. And what that just means is testing multiple genes all at once. So even though I provided those 2 examples to you on the previous slide, there's a lot more genes that can be tested for it with regards to cancer risk. And part of the meeting with a genetic counselor or a genetics provider can be to help determine what's the most appropriate test for you and what genes need to be included on your testing. And so, kind of the analogy is how wide are you going to cast that net to what genes are you going to include? And so you can see here in this little diagram, you can, sometimes you might want to cast the net wide enough to just capture the genes that are associated with the specific cancer type that you're concerned about. So for example, if you're seeing a family that mainly has breast cancer in their family, that's the main concern. Someone might, if they want to be relatively conservative, just go ahead and look at all the genes associated with breast cancer, but not really look at anything else. But now some of the labs that we use, they have around 84 gene panels that are basically what they call like a multi-cancer type panel, where they're looking at a number of different genes associated with various cancer types. And some of the factors that can influence the decision of which size panel to go with and how big you want the testing to be are, obviously not limited to these, but some of those factors can include personal or family history. So so depending on what we're seeing in the family, what the person who's coming in with, what their history is, that can influence what's the most appropriate test for them and how wide we need to cast that net. Of course, cost can play a role as well. Here in the US, with insurance coverage, that can be something to take into account, as well as what will insurance pay for. But also there's a patient choice that plays a role. So I will often see patients that can come in and are like, I want all the information I can get. So they will like to do the big panels, if that's kind of their choice, and they understand what that means, to get that information. But also there are times where maybe someone already has a hereditary cancer syndrome in their family and they just want to know that information, whether or not they have it. Then a single gene test for that specific gene would, that's in their family, would be most appropriate potentially in that case. Okay, so here's the fun part. So here is a family tree. Remember, we saw something similar to this earlier on. So I kind of wanted just to take a moment to, not only for me to get a sip of water, but to kind of show this to you guys and see, well, what patterns are you seeing? Pretend that you're now a genetics provider doing a risk assessment for this family. What are the things that stand out to you in this family history that make you suspicious that maybe this could be due to a hereditary cause? So feel free to, I don't know if you guys can unmute yourselves, right?
Hi, Fatma. Yeah, it takes a minute to do that. Do you mind repeating the question?
There we go. Oh, okay. Ooh. Am I still here? Can you guys hear
Yeah.
me?
Yeah.
Okay, perfect.
Do you mind repeating the question? Oh.
Did I miss anyone saying anything?
Yeah, if you can repeat your question.
Oh, yes. Sorry. So here's an example of a family tree. So what is it if you were to step into the role of a genetic counselor, for example, or you're looking at this family history, what stands out to you as something that might make this family history concerning for a hereditary cause?
Right. Great question. Eamon from the chat boxes said 3 generations involved.
Yes, exactly. So there's multiple generations that are affected here. So excellent. What else?
Am I allowed to cheat? I don't have anything else from the chat boxes. Let's see. I'm pick on Mujahid. Mujahid is on as well. Okay, also we have something from Fatima. Fatima said that there are rare types of cancer, like pancreatic cancer. And
yes, excellent.
Shanila says that there are young ages as well.
Absolutely. So yes, so pancreatic
here.
Right, exactly. See, you guys are ready to become genetic counselors.
All right.
No, I'm just kidding. But no, but yeah, pancreatic cancer is a rare cancer that stands out very good. Also that the young ages, like under the age of 50, is something that makes us a little bit concerned with breast cancer. So absolutely. There's two more things that I guess there's one more thing I can mainly think of
Yeah,
that
I can
hasn't
tell
been
you,
touched on.
Dr. M. Osman
Uh-huh.
from chat boxes said multiple primaries. The proband's mom has multiple
Yes,
primaries.
absolutely. Exactly. So that was the last that I was thinking of too, is there's multiple cancer diagnoses in this one individual here. So that is certainly something that makes us a little bit concerned. Now, for bonus question, does anyone want to guess what hereditary cancer syndrome we're thinking of here?
Give the chat box a second to load. Dr. Osman said again that this is autosomal dominance HBOC.
Yes, it is HBOC, you're correct, which is basically hereditary breast and ovarian cancer syndrome. So it's what we talked about, where someone can have a mutation in either BRCA1 or BRCA2. Very good. Okay, next one. So what are some of the things at play here in this family tree that make us suspicious that this could potentially be due to a hereditary cause? Dr. Rashid, you know already what this is. But yeah,
Suppress
exactly.
Dr. Osman's results.
All right, before we guess what cancer syndrome is, early age, very good. Yes. So yeah, early colon at 37, 42, definitely an early age to have that. But also, yeah, like kind of what was pointed out with Lynch syndrome, there's related cancers that we're seeing, right? So yes, exactly. Endometrial cancer. Like we talked about, Lynch syndrome, the main genes is, that are associated with it are for colon and endometrial cancer. So seeing them both together in a family makes us a little bit suspicious, kind of like a little bit of a red flag. So excellent. 3 generations. Yes, exactly. So you guys are doing a good job. So you got to get the hang of it, which is great.
Fatma,
yes.
I'd like to clarify a misconception if you want to go back to the previous example.
Sure.
So you'd see that in example like this one, that 50% of family members are affected and 50% are not affected, right? So you just see like 2 of the proband's maternal relatives, like an aunt and an uncle, were unaffected. The proband themselves is unaffected, but the brother is affected. And what this kind of can mislead to a person thinking that maybe if there were 4 people in the family, 2 will be affected, 2 will not be affected. Where this is very misleading, because the 50% chance is really each individual has a flip of a coin chance. Not that if there were 12 people in the family, 6 will have it, 6 won't have it. So I thought I wanted to bring that up.
Absolutely. Thank you for doing that, because absolutely, that's exactly right. It's a 50-50 chance each time that gene's going to get passed on. Okay, so I wanted to also just point this out. So I think Dr. Rashid, I'm assuming this is the same Dr. Rashid, because that would be a coincidence. So please feel free to claim these papers.
I think it is. I think it is.
But when I was doing just a quick search to see what do we know about hereditary cancer syndromes in Pakistan, I was very happy to see these papers be published by Dr. Rashid's group. And this is, I believe, a group based in Shaukat Khanum, that have looked at the prevalence of, for example, BRCA1, mutations in certain populations within Pakistan and such. And so, that is something that kind of the reason I wanted to share this is it kind of highlights that there are hereditary cancer syndromes in Pakistan. We're just not picking them up necessarily. So that just points to the need for genetics professionals in Pakistan, for genetics infrastructure in Pakistan, so we can pick up these patients and offer them the care that, can really change the outcomes for them. So we can, offer them the appropriate screening they need and be connected in their clinic where they need to be. So that's kind of all that I have with regards to my presentation. Before we open up for questions, I did want to quickly do a quick thank you and some acknowledgements that I have personally. Of course, thank you to the Pakistani Society of Medical Genetics for doing this, for hosting this series and for really organizing this, really playing such a pivotal role in working on creating a genetics infrastructure within Pakistan that's so important and so near and dear to my heart. And then I just wanted to share pictures of not only my parents, but my Nana Nani, who are now deceased, my Nana Nani, but they were all people who have spent time in Pakistan serving their, home country and using their knowledge and expertise that they've had to serve patients locally. And especially my Nana was a super patriotic Pakistani man, and he really instilled in me the importance of wanting to give back to your community and, using what I've learned abroad and to try to give that back to my home country. So something that I'm hoping to kind of honor him with today by giving this talk, and hopefully with my future involvement with Pakistani Society of Medical Genetics. Okay, so we can go ahead and open it up for questions. Aisha, are you going to be choosing the questions for me, I imagine?
So I have some questions already that came through the chat, and I have some questions that I would like to ask you as well. To the audience members, please go ahead and start typing your questions into the chat boxes, and I will share them with Fatma as they keep coming. But I wanted to start off by just thanking Fatma, first of all, for taking the time, and I'm sure your grandparents are looking down today and are very, very proud of you and all of your accomplishments and their amazing work that you're doing, and you will continue to do, not just for people in the States, but also for your Pakistani community. So thank you for that.
That's so sweet.
So let's start with a question from Shanila. I think we have tried to address her question in the chat box, but thought you could probably shed some light on that too. So her question is, how will you define loss of heterogeneity in context of cancer development? So I think this is a two-hit hypothesis sort of a question. So if you want to take that on, please.
Yeah, absolutely. So when we talk about, I know I kind of simplified it a little bit, but when we talk about loss of heterogeneity, so that's a term that we typically use, like when, for example, when we talked about this example where someone has one copy of their gene not working, for example, what can happen in a cancer cell often, or like what can lead to cancer formation, is that the other copy is also lost. Now that is dependent on also the kind of gene we're talking about, so I don't want to get into too many technicalities there, but typically what we see happen is, say for example, there is a tumor suppressor gene that whose job it typically is to protect the cell from forming into a cancer cell. Loss of heterogeneity means typically where now this person that already had one copy that wasn't working, now they've acquired a change or a mutation in that other copy of the gene that they had. That kind of basically is a loss of heterogeneity. So you'll have both copies that are not working anymore. That's kind of a simplified explanation of it, but I hope that kind of answers the question.
I think it did. That sounds great. The only thing I think I didn't mention in my response was the fact that we have environmental factors that continuously bombard our genes, whether it's just walking out in the sun or sitting in the car for too long because there's radiation there, or flights, or food that we eat, and there's just so much that we know that can cause these loss of heterogeneity events to take place. But yeah, that was a question. So then my next question, I think it stems from the fact that in Pakistan, there's a very high rate of consanguinity. I know you touched upon the role of autosomal dominant disorders that can cause different cancers. I'm wondering if you want to take a minute or two to talk about some of the autosomal recessive conditions like CMMRD or Fanconi's anemia, or even MUTYH and things like that.
Yes. So yeah, like I mentioned, most of the cancer syndromes we think about more commonly tend to be what we call having autosomal dominant inheritance, which basically, like this example here, you have to have one copy of the gene not working to have that increased risk associated with it. However, there are cancer syndromes where you have to have both copies of the gene not working properly for you to have its associated increased risk. And that's typically an autosomal recessive condition. Examples of that, so like Aisha mentioned, so CMMRD, which stands for constitutional mismatch repair deficiency. There we go. That's why we just call it CMMRD. But that is an example where actually someone can have a mutation in not only one copy of one of these genes, but actually a mutation in both copies of either, for example, their PMS2 gene, their MSH6 gene, et cetera. So for example, here, instead of this one copy being working, that person would have typically had both copies not working. And this can happen, for example, or actually a better way to maybe help explain that is, let's say that mom here also had a copy of the gene not working. And then dad here also had a copy of the gene not working. So for example, let's say they both had a mutation in the MLH1 gene, right? Each of them had a copy of the gene that wasn't working. They had one working copy though. There's then a total in that case of a 25% chance that their children together will inherit both copies of the gene that do not work. So then that child will have two non-working copies of a particular gene within Lynch syndrome. And that is when the child can have CMMRD, or which has increased risks for other types of cancers that often are have more childhood related risks. So these two examples we talked about before for Lynch syndrome and hereditary breast and ovarian cancer syndrome, these typically affect adults more so with their cancer risk. There's not really childhood risks that are established for them. However, for someone with CMMRD, where it's an autosomal recessive condition, they actually need to get certain screenings and be taken care of in childhood, and children are told to be tested as well for it. Similar to that, if you kind of translate that same example to BRCA1 or BRCA2, typically a child who is, let's say, both of their parents have a BRCA2 mutation, there's a 25% chance that they inherit both copies of the gene that don't work, and that child can then have something called Fanconi anemia, which also has more childhood implications compared to other cancer syndromes. So that's just two different examples. There's of course more as well, but yeah, that's kind of a brief example of that. And so, actually, one thing I should talk about is, so when you think about consanguinity, how does that really play a role? So consanguinity is the term that we give when two people are related and have children together. So for example, in Pakistan, where we can see a lot of people might marry their first cousins or someone that they're related to by blood, so let's say that there's a family in which there's a consanguineous marriage, and there is also a mutation in that family in, let's say, BRCA2, for example. If the consanguineous marriage is happening between two individuals who both carry the same mutation in the family, then they have a 25% chance of having a child together that has the autosomal recessive condition, or Fanconi anemia in this case. So you can imagine that in the context of a consanguineous marriage, if you have a mutation in BRCA2 and you will be marrying someone in your family, there's a more chance that you end up marrying someone also with the mutation in BRCA2 versus if you're going to marry anybody in the general population, since typically these mutations are rare in the general population. Now, I also am very much, though, the opinion that, some of these things are part of our culture, and I by no means am coming in to try to, we don't want to be just enforcing different cultures onto our culture. But I think where genetics can be important is for people to just be informed of their risk. So not to say that we say everybody should stop having cousin marriages, but to say that, this is what there is, so you can learn about the risks, you can do testing to be informed about your risks, and kind of make your own informed decision from there on. So there are actually, there's other countries as well where consanguineous marriages are relatively common, and on behalf of the government, there are services offered to do testing in their local populations to see whether or not they carry certain mutations to avoid any autosomal recessive conditions.
You did such a wonderful job, Fatma, with clarifying the concepts of
consanguinity and keeping in line with the traditional Pakistani family values. We know that there are tons of great reasons why people do marriages between cousins, and we know that strengthens the family values. And as genetic counselors, we are very well aware of that as a cultural value, and highlight that as a cultural value. And what we also highlight is the need for pre-test genetic counseling. Before a person is getting the testing done, here are all the things that you ought to keep in mind when you are anticipating result A or result B or a result C. And I think that's where genetic counselors are so invaluable and just immensely useful in that situation. So thank you for answering that. Now, we have a ton of questions coming in, so I'll speed them right over to you. So Amun Nadeem, I'm sorry, Amun, if I'm mispronouncing your name. She wants to know, can you please discuss HER2/neu in breast cancer settings and what that means?
So HER2/neu is something that is typically tested for as in terms of determining kind of like the hormonal profile of a breast cancer. So that's not typically something that we are, for me as a cancer genetic counselor, I've never ordered HER2/neu testing. It's not something I typically order. The purpose of that often is for the oncologist to be able to determine not only what type of, what drives this cancer, but also to determine what's the most appropriate treatment plan going forward. The only thing I can think of that's relevant to my practice potentially, and the reason I'm interested in knowing what the HER2/neu status is for breast cancer is also looking at what the other hormone status is, the ER, PR, estrogen, progesterone receptor status on a breast cancer. And this might be going into a little too much detail for some people, but basically the profile of the breast cancer can be either a hormone positive breast cancer. So usually where that means there's an estrogen, progesterone positive, ER/PR positive, HER2 negative potentially. But sometimes we can see a profile that we call triple negative. And that's where ER/PR is negative and HER2 is also negative. And that actually is relevant here, for example, in the study that was done by Dr. Rashid's group, where they saw that BRCA1 mutations, not surprisingly, were more common amongst women with triple negative breast cancer. We know that generally worldwide from other data as well, that women with the BRCA1 mutation are more susceptible to developing the triple negative type of breast cancer, which again is just where 3 of their profile markers or their hormone markers, which is ER/PR and HER2, are negative. That's just what that means. Again, you don't really need to worry about it too much if you're not an oncologist or someone who needs to worry too much about that. But yeah, so that is kind of what that is. I hope I answered the question.
I think you did a wonderful job. That was exactly the thought that I had about how does the HER2/neu status pertain to the practice of genetic counseling, and that's exactly what it is. Okay, so Salman Muslim has the next question, and their question is rather interesting, and they want to know why women are involved in breast cancer. What is the reason behind that?
Yeah, so interesting question. So breast cancer can actually happen in both males and females because both males and females have breast tissue, but we do tend to see more breast cancer, of course, in women. I don't know that I know like on a very pure technical biological level why that is the case. So please, if anybody else knows,
yeah,
feel
I
free
can add to that. I know it's a curveball that I threw at you.
Yeah, I know.
Prep. So the way that I would look at it is, and if there are any other genetic counselors with oncology background, please unmute yourself and add to this. But if you imagine a female has ovaries that is producing a ton of hormones, right? Mm-hmm. So we're looking at a male versus female, right? So why do women have more incidence of breast cancer? Well, because we're going through menses and we're having babies and there's hormonal changes that are happening all the time. And one of the things that it was mentioned earlier by Fatma herself, is the receptor factor, that there are estrogen receptors and progesterone receptors. And if you happen to have the kind of breast cancer that is dividing out of control because it's feeding off of those hormones, well, guess what? Women will have more hormones of these two hormones than men will, right? So that's a very technical, very nitty-gritty, like basic level of why women have more breast cancer than men do. There you go. All right, so the next question is from Hira Iqbal, and Hira is saying that keeping in mind Pakistan's scenario, how do we counsel patients and their families who get panicked after getting diagnosed with cancer, especially stage 3 and stage 4? So this is where our counseling techniques come in. So hopefully you can take this one, Fatma.
Yeah, that's an excellent question. You know, that's a good question. So one thing that I always like to be mindful of, even when I'm talking to my patients, as you can imagine, my spectrum of patients typically also includes seeing people who have stage 4 cancers and such as well. I think one of the things, that is helpful to recognize is not all cancer is the same. So depending on the kind of cancer, that can have very different implications in terms of the treatments that are available for it, the prognosis of it, meaning like how likely it is, what is kind of the likely path forward with that, for how we expect survival to be, et cetera, or the patient to do really in their care and going forward. But also, so the reason I mention that is because even though we use this umbrella term cancer, really the disease is different depending on depending on what cancer type we're talking about. So a stage 3 of a certain cancer might not be really necessarily equatable to a stage 3 of a different cancer. And I say that because, sometimes people will have seen a family member that had a late stage cancer of a certain type. And I always recognize is that for someone who has seen a loved one, has lost a loved one to cancer, for them to even get any of this information or potentially get a diagnosis of their own is especially difficult because they've seen someone they've loved go through that journey and maybe not have a good outcome at the end of the day. So that's certainly something where, one, it's really important to make sure you're well supported. So I think encouraging not only you to potentially be supported within your family. I think one thing that we really have that's great in our culture is having a collectivistic a family unit where, our culture is collectivistic in nature, meaning we tend to have family units and joints and so utilizing that to make sure you're well supported. And so that, you're being taken care of, in your life if you've had that diagnosis happen, but also knowing that, not to necessarily think the worst of it, just kind of rely more on your physician and see what they might have to say about it. They might have, a good, you might still end up living 20 years past your diagnosis. That's not, depending again on the cancer type, that may or may not be something that is, typically happens. So not equating it in your mind to a potentially different type of cancer is something that is certainly something to be mindful of. I don't know, Aisha, if you want to add anything to that.
Yeah, no, I think that, given the mortality of all of us, right? When facing that threat of our human mortality, any one of us will have panic attacks, or for lack of a better word, we will no doubt have those times where, especially the first few hours or minutes when talking to a doctor about that, it would shake any one of us, right? That's a humanity in all of us. And so to acknowledge that, I think, is very important. Just to say that what you are feeling is an appropriate thought. Like if, gun put to your head, you would feel some sort of panic waves too, right? And so for you to acknowledge that is, first of all, rather important. And then I would say, to bring the whole thing back about what Fatma said, rely on your doctor. Listen to your doctor, what the doctor has to say. They have treated hundreds and thousands of patients successfully, and they're living long lives. And in those cases where they're not living long lives, there will be those cases where, the cancer is a terminal illness in many cases. And so for them to understand that the family and the loved ones and the people that they surround themselves with and the positivity will make the rest of their days that much more better. And if there is a genetic component to it, then, of course, bringing in the fact that, nobody chooses to have a hereditary disorder. It is a natural way of things in life, and is not necessarily a person's fault, or take away the guilt and the blame. And that is very much ingrained in the training of a genetic counselor, and how we go about doing that, with what phrases do we use and what terminology do we use to de-escalate some of those. And when you take this genetic counseling course and become expert genetic counselors, you will have all those tools like empathy and unconditional positive regard for you, which I think is kind of very important. Okay, so next question is, actually, it's a very nice comment to you, Fatima, I wanted to tell you. Rabia Rizwi said that empathetic genetic counselors are a real need. The information cannot be stressed enough, and she wants to say thank you.
You're welcome.
The next question is actually not related to a genetic counseling thing at all. So I'm just gonna say the question and move on to the next one, because I just want to acknowledge the person who wrote this. This is from Saeed Rizvi, and they want to know, could you please discuss CyberKnife and the patient eligibility criteria? I'm just gonna move on because I don't think this has anything to do with genetic counseling. All right, so next question is from Nuzat Akram. Nuzat wants to also compliment you and did such a wonderful job on a very informative presentation in a very interesting way. She does have a question, which is, with the proof of a positive case in autosomal dominant risk, does the risk increase for successive births, or does it remain 50%? I think that's a question you can take.
Wait, could you repeat the question one more time?
Some of the time when I read it, the English doesn't do me justice. Sorry. So I guess the question is that if a child is born with an autosomal recessive disease to a parent who has an autosomal recessive disease, do the subsequent pregnancies or children have the same 50% risk, or is there somehow a higher percentage of risk for the subsequent pregnancy?
Yeah, that's a great question. So no, each time with regards to just having 2 copies of a gene, there's always going to be a 50-50 chance of it being passed on or not, of either copy. So having had a disease causing, gene or something like that is not something that increases your risk of just passing that one along in the future. It's just a pure 50-50 chance, even if, regardless. So that's a good question though.
Next question is from Mutahid, and he also wants to say thank you very much, Dr. Fatma. And
not a doctor, fun fact.
For this very informative lecture. And his question is there any Pakistani university that offers masters in genetic counseling? And so I can take this one because we know.
Yeah, I was gonna say.
Yeah, there isn't one. And we are working on it, and hopefully in the near future, give us a few more years and we'll try to tackle that one. The next question is from Sanila Khan. And first question that Sanila Khan has, I can answer, and then I'll bounce the second one over to you. So her first question is, what about genetic counseling for thalassemia? So Amreen Khan, who's a wonderful genetic counselor, did an excellent talk on this topic in our last meeting. And so if you want to go to www.psmg.org and go under the education tab, you will find all of our previous 4 lectures and their recordings in the in that page, or on that page. So feel free to go and explore and learn as much as you can about thalassemia counseling.
next question that she has is actually very interesting. And I think you might be the right person to ask this question given your telemedicine connections. So her question is, I would like to ask if telemedicine can help navigate through licensure issue for genetic counselors, and if a medium that can expand genetic counseling access internationally. Like, are there any restrictions stopping someone from utilizing virtual mediums for providing genetic counseling services?
Yeah, that's a great question. So, unfortunately, that even if, for example, you work through telegenetics here in the U.S. And are seeing patients across the country. So let me give you an example of, like, if for example, I'm seeing patients across the country in the U.S. Before I can see a patient in a certain state, from a certain state, I have to be sure that I'm licensed as a genetic counselor for that state if they have licensure laws. There are some states that don't have those laws, and so I can still see a patient there. But if there's another state that I'm seeing a patient from that has a licensure law, I have to make sure I have a license in that state before I can see them. So there's a whole process of applying for licensure for that purpose. Now, the reason I mention that is just to give you a sense of, there are kind of some legalities with, being able to provide your services to a patient in a specific place where you might not be licensed. So my understanding, and I don't work too much on the legal side of this or anything, but I think there's limitations in being able to see patients internationally, I guess formally, but maybe it's maybe more company dependent too or anything like that. But actually, you might actually be better able to maybe address that in terms of, because it's just clicking that, wait a second. Pakistani patients could be seen potentially, but so Aisha, why don't you take that one? Actually?
Yeah, no, right. No, I think there is a lot of potential there. At the moment, the way that genetic counseling is being performed by different groups. So you have your licensed genetic counselors that see patients in clinic. Obviously, for them, it will be very difficult to see an international patient over the telephone. That would be, I don't see how that would be not doable at all, but I can see how some hospitals will find that challenging. The second group that is now providing genetic counseling are those laboratories that are providing genetic testing internationally. So for example, a patient from Mexico orders a test from Lab A, and that Lab A is providing the genetic testing. Some labs are having a complimentary genetic information session. It's not a comprehensive genetic counseling session by any means, but just to provide the patient a little bit of information about, here's the test, this is what it does, here are the possible results in the pre-test settings and in the post-test settings. Here's the results, this is what it may or may not mean, go talk to a local genetic counselor, sort of a thing. So in those settings, yeah, I mean, if somebody from Pakistan is getting the test ordered from, let's say again, Lab A, can they reach out to their genetic counseling team and say, hey, I would like a genetics information session before I do the test? Sure. We could probably try to do something like that. At the moment, there is no such advertisement from any of the laboratories that I know of that are offering genetic counseling to people that are in other countries other than the United States, not even Canada to my knowledge. But that is something that is not a bad idea and should definitely be considered. Of course, there will be a language barrier. US genetic counselors don't speak many languages, which is a real detriment to the profession itself, of how not diverse it is, which is a different topic for a different day. But we know that, that will be a challenge. So if you have a typical Pakistani family looking for genetic counseling, they probably can't see a genetic counselor in the United States unless they offer that they're getting testing done from a particular lab and they are English speaking, or at least have decent understanding of English where they could communicate. Because yeah, we have translators, they're not always very good, FYI. So yeah, sorry, that's a great that's a great question and something to ponder upon further. And we will take that back to the drawing boards and definitely think about that. Good thought. Next question is from Fatima Al-Turki. her question is also very interesting, and she wants to know, is there a routine practice to provide PGT options for families with hereditary cancer worldwide?
Oh, worldwide, I don't know. But yeah, I mean, PGT is certainly an option available to patients. I know here in the United States, even here in the United States, there are some places where there might not be something immediately locally available. So people might have to travel a little bit to go get that process done. But I'm not sure of anyone that's offering that service worldwide. So
Yeah, I don't know either. Worldwide, we're so illiterate when it comes to outside of US laws, and so we don't know about worldwide. But yes, in the US, if a person is found to carry an autosomal dominant, or even some cases, couples that have autosomal recessive genetic, are carriers for autosomal conditions, are offered PGD. Oh, for those of you who don't know what PGT is pre-implantation genetic testing. So this is when the couple goes through an in vitro fertilization doctor, an IVF specialist. They then select the embryos that are unaffected by the hereditary disease and only implant those back into the female's uterus for the future child or children to be born to not have the disease. Yeah, that's a great question. We don't know. Next question is from Sidra Rehan. And Sidra Rehan's question is, professionally, what issues may international graduate students of genetic counseling programs face in US and Canada, if any? How do growth opportunities in non-direct patient care like industry, lab, or policymaking differ from direct patient care for genetic counseling?
yeah, that's a great question. So so let me try to answer the first part of the question first, which is international graduate students and what challenges they might face. Now, I'm not quite sure if you mean like they've graduated from a genetic counseling program internationally and want to work in the United States,
I think
and
it's
what the
that fair,
challenges.
and I think this is for students that are a bachelor's in Pakistan and want to come to the US for a genetic
Okay,
program in US or Canada.
got it. Yeah, so I think to my knowledge, I want to say that there might be some places that might not. Well, okay, so let's start with the school itself. I have had international students with me in my graduate program. I remember when I went to the University of Cincinnati's program. So it is doable. Like people do, you can be an international student in some of these genetic counseling graduate programs. I think some of the challenges afterwards can be certain institutions might not be hiring anyone who they need to sponsor for a visa and such. So that can sometimes make it potentially a little bit more difficult to find a job compared to someone who doesn't need to be sponsored with a visa. Granted, again, I do still know people that were international students and they have jobs. So one of the things that is kind of nice about genetic counseling is there's a high demand for it. So there's quite a lot of jobs that are typically available, and people don't typically have too much trouble finding jobs. But that is something that I can see as a potential challenge. I think the other thing is just one thing we've been actually working a lot in the profession now to talk about like how our underrepresented populations within the field. So for example, our field is the genetic counseling field in the US right now, like Aisha pointed to earlier, is not very diverse. So it's about 90% white female and not a lot of representation of other groups in the field. And that includes, lots of different types of diversity groups when we talk about it. So even including international students, there's not a lot of international students and such. So that can sometimes make it, can also, of course, impact, in some cases, there's been studies that are now looking at this to look at how the experience was in graduate school for people that were underrepresented, and maybe, sometimes people might have felt isolated and stuff like that. But I'm sure that can also happen in potentially other fields too, where if you're coming internationally to a new country and like kind of the challenges that just kind of come with that as well. But that is certainly something that I think people are trying to be more aware of as well now. And what was the second part of the question? I already forgot.
Yeah, if you wanted to know what are some of the growth opportunities in non-direct patient care, so industry, lab, policymaking, that
Yeah,
are
so
different
that's
from
yeah,
traditional.
yeah. Yeah, that's actually a growing area. And, there's lots of obviously genetic testing labs that are out there, but also just other industry, groups and industries. And technically, like where I work is technically industry too, because it's a telegenetics company. So, it's not like a hospital. Previously, I worked at a hospital, which was more traditional. I still get to see patients in my role, but there are people working in industry that are working on, say, variant curation. So when we talked about, like, for example, the genetic testing earlier in our presentation as well, and what that process involves and looking at certain variants, there's a whole process that goes into that of how to determine what variant is harmful and such. And writing the reports that get sent out to the patients and stuff. So there are genetic counselors that work in roles as such. There are genetic counselors that work as like a medical science liaison or something like that, which basically often can involve some elements of sales and such like that, of the products that are at the lab that they're working at, and talking with providers and potential, I guess, clients in a way to talk more about that. So if you're more into like sales and business, there's certainly opportunities and stuff there too. But yeah, it's really, honestly, it's evolving, and there are so many genetic counselors that really make their role their own. Like they kind of just start, going into these new areas and discovering new roles, working for companies that were very non-traditional. So, and I really like that you mentioned policy making, because that's a huge thing. But yeah, I mean, whether it's with regards to working with health insurance companies and like thinking about policy on that level, or policy, advocating for policies on a more governmental level that can help increase access for genetic counseling and testing. Those are all things that genetic counselors are working on. So we're actually trying to move away from the traditional versus non-traditional, because now, we're seeing a growth in the numbers of people that are in those non-traditional roles.
Yeah, absolutely. I hope that answered your question, Sidra. Feel free to write to us if you guys have any additional questions about this particular talk or one of the other talks that we've had in the past. Our email is on the psmg.org website. You just go to the website and there's a box there, and you type in your question and send them to us. And we try our best to reach out to as many people that get back to us and that write to us as possible. With that being said, there were some comments that were coming in about, I think, marriages and consanguinity and something about genetic counseling. So I would table that for another day. And, of course, we try to do a very, very culturally aware point of view. We never say, don't do this or don't do that. We're very patient oriented and always try to keep the patient's social cultural reality in mind. So I just want that to be the focus from that conversation. Just like PSAs go out about don't smoke or don't do drugs or don't do this or that to help patients make informed choices. I think our plan is very similar to something like that. Not to say, don't do this or that, but just to know that here are possibilities and here are the genetic counseling things that you can tap into for that kind of conversation, if you want to have that kind of conversation, that is, at all. And so that being said, I want to conclude our conversation by thanking Fatma again so much for taking the time out of your busy schedule. And I know you're entertaining guests of the house right now. And again, I want to say thank you so much for taking the time to do this talk. Very insightful. I'm getting a lot of comments in the chat box. Everyone's saying very insightful. Thanks a lot. Great work and all that. So I want to echo everybody's sentiment, and I want to wish everybody in the United States a happy long weekend for Memorial Day, and everyone in Pakistan, thank you so much, and Shabbat.
Thank you so much, everyone. Thank you, Aisha, for having me.
Goodbye.